Continuing with sickle cell anemia, we'll look at the pathophysiology. So what happens is we get obstruction caused by those sickled red blood cells. And this is called a vaso-occlusive crisis, and it leads to tissue hypoxia. So those sickled cells catch on each other, clump up, can't pass through little bends in the microcirculation. The tissue beyond them doesn't get oxygen, so it becomes ischemic. If it doesn't get oxygen, it goes from ischemic to dead, to infarction. Those cells die, they clump and destroy each other and break, and so we get anemia from destroyed red blood cells. Now, we don't really see crisis in the newborns because they have 60 to 80% fetal hemoglobin. It's only the adult hemoglobin that has the problem with sickling. So it's not until the child's over a year that we will usually see signs. There is a test for sickle cell trait. If a child comes back positive for that, it's part of the newborn screening, then they need to go on and do the hemoglobin electrophoresis to see if the child only has the trait or if they have the actual disorder. Now, in a crisis, we can have the vaso-occlusive crisis, and that's where you get ischemia and pain. Pain is the biggest problem that we're trying to control in the hospital usually. Distal from those areas that have gotten occluded. We can get a sequestration crisis, and this is our hepatosplenomegaly. So the spleen and the liver pool with blood. And you can become hypovolemic. You can see shock syndromes from this. Aplastic crisis means they just don't have enough red blood cells from breaking down all those red blood cells. We're seeing profound anemia and just very low red blood cell count. And then hyperhemolytic crisis. This would be an accelerated rate of breaking down those red blood cells. And you're going to see anemia, jaundice, and reticulocytosis. Other complications, they can get acute chest syndrome. And this is basically the same things happening, but it's in the pulmonary and or cardiac systems. So pulmonary infiltrates, and it's associated with chest pain, fever, cough and tachypnea, wheezing, and hypoxia. You can imagine we already aren't circulating enough oxygen well, and now we're plugging up the microcirculation inside the pulmonary system. You can see how that would make even worse hypoxia. And then if it happens in the brain, we're at risk for a cerebral vascular accident. So those sickled cells block the vessels in the brain, so you get hypoxia, and can lead to infarcts beyond that, or bursting the cell and getting a true CVA. Or not bursting the cell, bursting the vessel. Newborns can be screened, and then if they're positive, we know they have the trait. So we do the hemoglobin electrophoresis, which is looking at the fingerprinting of the protein on the cells. The sickle cell turbidity test is a quick test that only takes 3 minutes. It tells us if they have the trait or not. Now, management. Our management is to prevent conditions that are going to cause sickling, illness, anything that causes acidosis, anything that causes hypoxia, dehydration. So preventing illnesses and doing prophylactic antibiotics may be a consideration. And then we want to treat any sickle cell crisis that they're in. And when they're in a crisis, the big thing we're treating for them is pain. It's extremely painful. So analgesics for the pain. We want to keep them hydrated to try and push through the cells so they don't get stuck in the little micro vessels. And also dehydration, we said, is going to make more sickling of the red blood cells, so we want them overhydrated. We want bed rest. We want to minimize the energy consumption that the cells need, the tissues need. We don't want them using energy, and we want to decrease the O2 need of the cells. We're going to have to think about electrolyte replacement because there could be a metabolic acidosis going on that triggered the sickling, so we may have some electrolyte imbalance. We may have to do blood replacement. Remember, the cells break, they end up anemic, so we may have to decrease the anemia, and then decreasing the viscosity of the sickled blood. Part of that is by that overhydration. Antibiotics to treat infection, oxygen and heat if they help for comfort, the warm packs, trying to dilate vessels and get things moving through there, and oxygen, trying to maximize what hemoglobin they do have, that it's all carrying oxygen. Hydroxyurea, this is going to increase the production of fetal hemoglobin, reduces endothelial adhesions of the sickled cells, improves sickle cell hydration, and has a 40% reduction in mortality and decreased frequency of vaso-occlusive crisis. Another treatment, hematopoietic stem cell transplantation. This is normally used in cancers. This is only going to be a cure for some children, and it has a fairly high mortality rate, only about 8%, so that makes it a little bit controversial. Now we're changing diseases to thalassemia. This is also an inherited blood disorder, but this is a problem with hemoglobin synthesis, so making hemoglobin. It's classified by what chain of hemoglobin is affected and by the amount of the effect. This is an autosomal recessive, but there's varying degrees of expressivity. So both parents must be carriers to have a child with this. Now, the pathophysiology of thalassemia, the anemia results because there's a defective synthesis of hemoglobin. So we're not making normal hemoglobin. They are structurally wrong, the RBCs are, which means they have a very short life because they're not what they should be. They break way too easily. So what you see from this is chronic hypoxia, because we don't have enough RBCs because they're breaking down too quickly. The sort of signs you'll get with that chronic hypoxia are headache, irritability, precordial and bone pain, exercise intolerance, they don't have a reserve of oxygen, anorexia, epistaxis, that's nosebleeds. This can be detected in infancy and toddlerhood, hopefully, they'll look pale, probably be failure to thrive because they don't have adequate hemoglobin, they're not bringing adequate oxygen to the cells. They get the hepatosplenomegaly, and they can have very severe anemia. Now, B-Thalassemia, which is also called Cooley's anemia, this is one type of thalassemia, and it's specific to what chain of the hemoglobin is not normal. And so what you get with this is an overabundance of red blood cells are formed, but remember, they don't live long, and they just aren't right. So we're constantly making more, and you get this overformation even though there's never quite enough. They have such a short life. We're constantly making more. And so we've got to stop the bone marrow from making all of those extra, just that constant work of making red blood cells. And we do that by giving them transfusions. So the treatment for Cooley's anemia, which is beta thalassemia, is regular transfusions. giving them normal hemoglobin to slow down that overproduction of red blood cells in the bone marrow. This is primarily seen in descendants of people in the Mediterranean area, around the Mediterranean Sea. The medical management is transfusions. These kids often will need a splenectomy, their spleen removed. And another complication we have to watch for is iron overload. Because they're making and breaking down all this hemoglobin really quickly, they end up with a lot of iron in their blood. And so there is an iron chelator. Remember, we did chelation for lead. There's also medication for iron to pull the excess iron out of the blood. And here's a algorithm showing what B-Thalassemia, what happens in the bone marrow, that overproduction, defective RBCs, and then they become hemolyzed, and then going out and affecting the spleen and the lymph system. You end up with the anemia, bronze-colored skin, and fibrosis, so little scar tissues all over the lung, the liver, the gallbladder, the pancreas, the spleen. And here's a picture. This is that bossing. See how large her forehead is? That's because your body is trying very hard to keep up with making enough hemoglobin, enough red blood cells, and so all of the bones that have a lot of marrow in them grow too big to have more marrow to be able to produce more red blood cells. So you end up with this bossing of the forehead, the large forehead, to compensate for making all that blood. The problem is the red blood cells are not effective. We need to give them transfusions. Okay, aplastic anemia. This means that everything is decreased, not just one part of the blood, not just the red blood cells or the white blood cells, but across the board everything is decreased. This can be primary, congenital, or it can be secondary, caused by something else. And so to get a definitive diagnosis on this, we have to do a bone marrow aspirate, and we'll see that the normal red bone marrow has turned yellow. So the treatment for this, the therapeutic management, is we give immunosuppressive therapy, which is your chemotherapy. We're probably going to need to do a bone marrow transplant. We have pretty good survival rates. 70 to 85% of kids will have a 15-year survival rate. Some of the other medications we use, anti-lymphocyte globulin or anti-thymocyte globulin. Hemophilia. I think I'll stop here.